Dear audience, in my next presentation I would like to perform to you the cognitive issues in multiple sclerosis, and my related PhD project whose title is The Prevalence of Cognitive Impairment and its Prognostic Significance in Patients with Multiple Sclerosis. Few words about myself and my research team. My name is Katalin Lugosi and I am a neurologist specialist in Bajcsy-Zsilinszky Hospital. My vision is we strongly believe in that broad insight into consequences and prognostic significance of cognitive impairment can provide better interventions to patients, leading to more favorable disease course. And our mission is the following: to expand MS patients' follow-up strategies and develop the most personalized treatment and neurocognitive rehabilitation management for everyday clinical practice. First of all, I would like to give you an overview about our main projects for understanding cognitive performance in multiple sclerosis. Our first project will be a meta-analysis. The title is Prevalence of Cognitive Domains Impairment in Different Clinical Subtypes of Multiple Sclerosis. And our second project is a registry. The title is Establishment of an Early Stage MS Registry. But what am I speaking about exactly? What is multiple sclerosis? Multiple sclerosis is a chronic demyelinating central nervous disease which affects 2.5 million people worldwide, and any central nervous regions could be affected. I mean, it causes various neurological damages like visual impairments, spinal cord disabilities, gait disorders, speech disturbances, vegetative disabilities, and cognitive decline as well, and so on. And there are 4 main clinical phenotypes of multiple sclerosis: the clinically isolated syndrome, the relapsing remitting multiple sclerosis, the secondary and the primary progressive multiple sclerosis. And interest in neurocognition of multiple sclerosis grew after a large developed psychometric studies and MRI scans just in the 1980s. And now we have got excellent disease-modifying therapies for treating of a patient, but we don't understand exactly the cognitive decline, the role of these therapies in cognitive decline. At all, what is neurocognition? So what does it mean, neurocognition? You can imagine it like a mosaic of 6 main cognitive domains: the perceptual motor function, the language function, learning and memory, social cognition, complex attention, and executive function. And these skills are required to a healthy and integrated way of thinking. So let me move on my first project, the meta-analysis, the prevalence of cognitive domains impairment in different clinical subtypes of multiple sclerosis. So why is it important, the cognitive impairment in multiple sclerosis? Because first, the prevalence of overall cognitive impairment among multiple sclerosis patients has been reported to range between about 40 to 70%. So it's a huge amount, I think you agree with me. And it's very important because, one hand, because of the patient side, because probably they may even lose their jobs, their livelihood, their families, and so on. And in the other hand, from the doctors and caregivers side, because, for example, if I recognize cognitive impairment in a given patient with multiple sclerosis, in the future, it can be an imperative task for me to change her or his therapeutic agent for a more cognitively effective one. So this study may add, this can be a comprehensive meta-analysis for each clinical types of multiple sclerosis and for different clinical cognitive domains by providing the best initial therapeutic decisions and most individualized neurocognitive rehabilitation strategies. Our clinical question is, what is the prevalence of cognitive domains impairment in different clinical subtypes of multiple sclerosis? How can we measure it? As you can see in this slide, we can measure with BRBN test, a repeatable battery. It's a battery, it's a composite of neuropsychological tests that includes the single-digit modalities test for the complex attention, the PASA-3 test for the memory, the word list generation test for language functions, the special record test for the perceptual motor functions, and the simple reaction test for executive function. And we hypothesized that the decline in learning and memory, language, complex attention, executive function, perceptual motor neurocognitive domains have different prevalence in these four main phenotypes of multiple sclerosis. And now we arrive, I think, the most important part of my presentation, the clinical implication. So with this knowledge of the clinical, recognizing the clinical features and clinical significance of cognitive impairment in multiple sclerosis is an aid to making more individualized therapeutic decisions with early neurocognitive rehabilitation. Here you can see our systematic search. We use three main databases, Medline, Embase, and Central. And we are now just at the title and the abstract selection step. But we have got more than 10,000 articles, so it's a huge amount of articles. It's a hard work. That's very exciting work for us. And let me move on my second project, a registry. One of the biggest challenges currently associated with multiple sclerosis is to find a prognostic marker which can be sensitive to progression of cognitive impairment. MRI scans are used in clinical practice to assess the progression of cognitive impairment, but it still faces a number of challenges. I mean, for example, differences of quality devices, differences of softwares and protocols, the application of the same criteria for follow-ups, and of course the cost of the devices and the investigations. So that's why it has not been become a part of a clinical routine. That's why we decided that to find easily accessible, inexpensive, non-MRI based prognostic marker in cognitive impairment progression can be an aid in clinical practice. Here you can see our registry resources, human and financial ones, and two multiple sclerosis central will be involved, our workplace and the Department of Neurology, Semmelweis University. We will include patients between 18 and 50 years old, and it's an additional requirement that the patient is able to, must be able to walk. And what we'll have been measuring by plan, age and gender, of course, and several aspects of several aspects of skills in multiple sclerosis. I mean cognitive affective, as I mentioned earlier, the neuropsychological tests supplemented by the anxiety, depression, and fatigue scale test, the functional aspect of the disease, the expanded disability status scale, the 25-foot walk test, and so on. These are measurements of extremity disorders and gait disorders and so on. Morphological aspect of the disease, MRI scans, T2 lesions, activity, cortical thickness, and in addition, liquor chemical measurements by these biomarkers. So these are our specific goals with two main investigations for understanding of cognitive performance in multiple sclerosis. And I would like to summarize my thoughts with Jean-Martin Charcot's work, he was a father of neurology, and he discovered first the multiple sclerosis in 1877, And he said about cognitive impairment in multiple sclerosis, it's a marked enfeeblement of memory, conception that works slowly, and intellectual and emotional faculties are blunted in their totality. So I think he discovered very exactly the essence of our knowledge just 150 years ago. Thank you for your attention.
Congratulations for your presentation. My question about your registry, how many patients are required to prove this prognostic role? How many patients are needed, and how many patients can you include in from your institute?
Yes, thank you for your question. I calculate with, I don't know, you know, as I mentioned, we will measure with 2 multiple sclerosis centers. For example, from my hospital, I think annually 10 or 15 patients will be enrolled. And from the Semmelweis University, about, I don't know, more, of course, 30 or I don't know, annually, yes. And it will be measured years, 4 years.
Thank you for this very detailed presentation about multiple sclerosis. Actually, my question is related somehow to Marty's question, and would like to also challenge your ambitions regarding this registry, because actually you told quite a low number of patients in this registry. Do you think that this number is comparable to the analysis already in the literature, first of all? And why not plan bigger and have a national registry regarding multiple sclerosis?
Yes, thank you. For the first question, I think it will be enough, because not to forget, it's an early stage MS registry, not a general MS registry, and it will be measured 4 years at least. And yes, there is a MS registry named MS Base. It's an international MS registry. But our registry, it will be just early stage, so specified MS registry, early stage MS registry.